So, hello everyone. So, in this chapter, we have learned so much about different theories or hypotheses that explains the health disparities in the US. Hopefully you are getting a good hold of it. There are a lot of reads and there are many different theories that actually explains the different health outcome between different populations. It's important for policymakers to actually understand all these effects. So today we are going to specifically take a look at one of the examples that might actually given us some evidence to believe the efficient producer hypothesis. So in this example here, we are basically looking at a study. This study actually separates two groups of people. One group of people is people from college, and the other group of people are people from only high school graduates or maybe completants of their high school degree. So obviously there is one group that has a higher education attainment versus another group might have a lower education attainment. So we are basically separating these two groups into another two segments. So one is the group where people actually taking the regular drugs to recover from the high blood pressure problems. And there is another segment. It's divided up into the people who actually taking these new drugs to actually control these high blood pressures in these two populations. So in the groups where the people taking the regular old conventional drugs, we actually see the baseline number here. So the baseline number basically represents the data for patients who actually not taking any medicines. So obviously both groups of people actually suffer with the high blood pressures because the ideal numbers that you're supposed to get is 120 over 80s mmHg, and both groups are actually over it. So that means they are both at the risk of high blood pressure problem. So in this case, we are basically trying to figure out, well, given the drugs, the conventional drugs to both groups of people here, how is it going to affect their outcomes? So after the end of the study, we actually find that the numbers actually does not go towards to the normal level. Indeed, we actually see the problem go worse. So we can actually take a look at the difference here. So the difference actually explains to you, well, how much of a difference measure before the study and after the study. And both groups actually result in a positive gains of the measurements. So again, the ideal way to think about this study is they both taking the drugs the same way as prescribed by the doctors, but somehow both groups are not being treated by this old conventional drugs, and both groups are actually getting worse. Well, take a look at the new drugs. So two populations actually share a very, very similar backgrounds comparing to the other group that has the conventional drugs. Well, after the end of the study, after taking the new drugs for a period of time, we actually find this new drug actually has a significant effect on both groups. So we actually see the difference between these two groups are pretty close, and obviously the people who belongs to a college graduate populations, actually they're taking this new drugs will have a much greater result coming from this new drugs. So how is this number or study can actually illustrate the disparities between educated populations to less educated one? Well, we can actually first take a look at the individual effects. So when we are actually comparing the difference between the two drugs in the study, obviously the college student who taking the old drugs actually has the hyperpressure problem go worse, but not as much as the high school graduate ones. So in this case, the high school graduate population taking the old conventional drugs, it's actually getting hurt by the old conventional drugs. On the other hand, if we look at the individual effect of the new drugs, the college students or the college graduates obviously has a much better or more ideal result coming from these new drugs compared to the high school, because the college graduate actually has a much higher level reductions of these numbers and getting into the normal range comparing to the high school graduates, where they still have a bigger magnitudes comparing or maybe some level of decrease in those data, but still not getting them into the safe zone in this diagnostics. So in general, we say, well, after studying these numbers, we can actually conclude, number one, well, the high school actually suffer a bigger deteriorations because they see the numbers actually go up more than what the college's graduates are. And the college had the biggest improvements from the new drugs, because obviously we can see a better result that's being captured in this study. But what's important to actually evaluate in this study here is to take a look at the treatment effects. So in this case, the treatment effects explain to us the difference between the old drugs and new drugs within different groups. So we want to actually see, comparing the result of the conventional drugs and the new drugs, how is it going to make the college population better? Or comparing to the old drugs and the new drugs and seeing how the high school graduates will be benefits from the new treatments. So in this case, in order to calculate the treatment effect within the college populations, we have to use the individual effects for the college students taking the new drugs, which is -8 and -4, minus the college populations or the college graduates who are taking the old drugs, which is 2 and 1. So when we're subtracting the number here, we are actually getting the difference between the new drugs and old drugs. So how much does it actually improve the college graduates' health or improve the high blood pressure conditions between the old conventional drugs and the new drugs. So in this case, the college graduates actually getting the benefits to comparing the two drugs by reductions of the high blood pressures data by -10 and -5. So it's a much better results, right? So instead of taking the new drugs, well, instead of taking the old drugs, the new drug actually has a much better result, right? Comparing the two options that they have. I'm not gonna show you how to calculate the treatment effects for high school graduates, whether I will let you do it on your own, but the data actually readings -13 and -7. So you can actually try to work out the number yourself and see if you get the same number. But here, the very important conclusion here in this example is, when we are actually comparing the treatment's effects between the college populations and the high school graduates, the college students or the college graduates, they actually benefits less from these new drugs comparing to the high school graduates. So in this case, obviously, by providing these drugs to the high school graduates, they will be benefits the most. This has a very important policy implications. So in general, that means, well, the college students or the college graduates populations, obviously, they can actually do much better on their own without even taking the drugs. Comparing to the high school graduates, if we are not assigning the drugs to this group of people, well, they will have a much higher opportunity or higher risk to be suffer from this high blood pressure problem. So this has a very, very important illustrations on how the efficient producer hypothesis explains the reality here. So obviously, college graduates, they are a better health producers. As we studied in the previous chapters, we know it because they have a better education background to understanding the informations, or maybe in this chapter we also explain maybe the college graduates or higher education attainments populations, they have a better understandings of the procedures, of the treatments, or maybe they are just better adherents to the treatments comparing to the high school or maybe a lower education attainment populations. So this policy implication has a very important effect to understanding, well, how to assign different treatments to different group of populations in society in order to achieve a better health outcomes in the society. So other than the efficient producer hypothesis, of course, we would like to use some other example to illustrate the health disparities that could possibly happen. And in this example here, we are trying to use this data we collect from hypothetical data, first of all, to illustrate the direct income hypothesis, how income can actually driving its disparities between different income groups of populations. So in this data, we are actually taking a look at some hypothetical data about lung cancer that is captured in 2 different cities. So in San Francisco, where I live, and also San Jose, which is another big city in the Bay Area in California. So they are relatively close, but then the demographics between the 2 cities are very different. So first of all, let's take a look at the populations within each city here. So the populations for people who earn an income that higher than 100K a year in San Francisco, there were about 12,000 people. And the population that earn less than 100K a year, it's about 10,000 people. On the other hand, in San Jose, well, there are about 4,000 people that earn an income that it's over 100K a year, and about 90,000 populations that earns less than 100K. Well, we are trying to actually take a look at some of these hypothetical data here. So the cancer ratio in San Francisco for the high income population is about 15% out of the 12,000 populations. And the cancer ratios in San Francisco for the low income is about 12% out of the 10,000 people here. On the other hand, San Jose actually has about 30% of the population from the high income family actually result in the lung cancer out of the 40,000 populations. And about 25% of the low income people actually getting the lung cancer of the 90,000 populations here. So by only looking at this result here, obviously people will believe, you know what? In general, the high income population actually has a much higher cancer ratio compared to the people living in the same city, but has a lower income. Does it tell us the full story here? Is it really true people earning higher level of income actually has a much higher chance to get a lung cancer compared to the low-income family or low-income individuals? Well, we have to actually separate this data into a different way to evaluate. So first of all, we would like to actually calculate the cancer ratio within the same income population. So that means we would like to actually know exactly, well, what is the ratios for the high income populations in both cities combined. And at the same time, we would like to know, well, what is the cancer ratios within this low income populations in the two cities combined. So that means we have to first do a little calculation here. In order to calculate the number of cancer populations within each city, divided up into two different income groups, we have to actually calculate the high income populations in San Francisco who has cancer by using the total population, 12,000 people, multiplied by 15%, then we get 1,800 people. So this is the exact number that actually has lung cancer recorded in San Francisco, which has a high income. And you can actually do the same thing for San Jose. So we have 4,000 people in San Jose, and 30% of the people are getting the lung cancer. So the total populations for people who has high income living in San Jose who get lung cancer, it's 1,200 people. And I would suggest you to do the same thing for the low income populations yourself, but the idea is pretty much the same. You are basically using the total populations in this income group multiplied by the cancer ratios in the table. So after calculating these numbers, we can now actually illustrate the true cancer ratio within each income group's populations. So in this case, we have combined both cities, 3,000 people who got lung cancer. And the total populations of the high income family or high income individuals are combined to be 16,000 people. So we are using 3,000 people divided by 16,000 people and then multiplied by 100%. And the final result in this calculation is we actually find out the high income population actually has a true cancer ratio of 18.75% approximately. On the other hand, we can also calculate the true cancer ratio for the low income populations. So we have combined of the two cancer patients in both cities, which adds up to 23,700 people, divided by the total low-income populations in both cities, which combine to 100,000 people, and multiplied by 100%. And finally, we get the true cancer ratio for the low-income population. It's actually 23.7%. Well, by looking at this number here, obviously, now we find out if we are only based on this information here by two separate cities, we might actually get an illusion that the high income population might actually have a higher level of risk to get the lung cancer. But indeed, is it true? Well, after we calculate the cancer ratio within each income group, we actually get a very different results. So surprisingly, this nationwide cancer rate is actually about 5% higher for the low-income family or low-income individuals, so as of the high-income groups in the Bay Area. So the conclusion in this study here is the counterintuitive results arise from this fact that most of the low-income actually lives in San Jose instead of San Francisco. And it might be because of the fact that people living in San Jose, they tend to have a higher chance to get unhealthy or maybe to get sick comparing to people living in San Francisco. So how is this result actually explains the direct income hypothesis? Well, in general, you can actually think about if you have money in your pockets, you can actually choose to live in a more healthy environment, well, which is San Francisco, or a less healthy environment, San Jose. Given the level of income you have, and you have the choice to choose between the two, obviously you would like to spend more money to live in San Francisco to become a little bit healthier. So that means people who actually has the income to spend on where they want to live, well, now they have a choice to move to a healthier area to live. But people with lower income, obviously, they're stuck with the choice of the unhealthy city, which is San Jose. Well, in this case, well, they have to actually move out from the healthier city and to a more unhealthy city. And that's what explains the data here. Because obviously, you can see the risk for having lung cancer, it's much higher in San Jose compared to the city in San Francisco. So with higher level of income, people is given a choice to move to a more healthy city or locations. And that's what explains the direct income hypothesis. Sometimes with the extra resources have from these individuals or households, well, obviously it will directly affecting the health outcome. Depends on how they spend the resources to get a better health in the future. So next time we are going to talk about the supply side of the healthcare sectors. So we are going to move away from the demand side, but still all this chapter that we have went through are very, very important to our future study. So make sure you get a good hold of these chapters, and then we will try to revisit them later when we talk about a more complete national study of the healthcare system. So I will see you next week.